How's it going, guys? Past level question for Gastro. We got a 31-year-old woman who has ulcerative colitis, and we know that because the contrast enema is showing us the lead pipe appearance, which is loss of haustra. It's very classic for ulcerative colitis. You don't even need to read the question here. Crohn disease, in contrast, you're going to see string sign, which is segmental inflammation, where you get narrowing of the large bowel lumen. It's actually mouth to anus with Crohn. Okay, so it can be anywhere from literally the mouth, where you can get mouth ulcers, down to anus, whereas rectum ascending would be ulcerative colitis. Okay, but when we talk about the barium imaging here, it's the string sign you're going to see with Crohn. It's going to be the lead pipe appearance with ulcerative colitis. Now, let's just hop to the answers. We'll tell you some more information, contrast. But just real quick, the anemia here, this could be possibly anemia of chronic disease. There's been blood in the stool. You say, well, it could be iron deficiency anemia. That's fine. But for instance, if they were to just give you a low hemoglobin in the setting of IBD, SLE, RA, it doesn't matter. You have to be thinking of anemia of chronic disease. Okay, and the MCV doesn't have to be normal. The MCV can be low in about 50% of questions with anemia of chronic disease. So let's just hop through here. Choice A, creeping fat, that's wrong because that's Crohn disease. So you have the transmural inflammation with Crohn disease, where that's going to stimulate, the cytokines are going to stimulate the mesenteric fat to wrap around the bowel. It could be a protective effect, possibly, the abdominal cavity is trying to implement. But regardless, you can get grossly the appearance of fat on the outside of the bowel. It's called creeping fat. You see that with Crohn disease. You do not see that with ulcerative colitis. Wrong fucking answer. Choice C, crypt abscesses, correct answer. So in ulcerative colitis, you're going to have accumulations of neutrophils within the GI crypts, and they're called crypt abscesses. I don't really know what to tell you. They can show up in vignettes. They'll say them, and you just have to know that's UC. It's not characteristic of Crohn. Now, you can also get pseudopolyps in ulcerative colitis, which you do not see in Crohn. The inflammation of the bowel leads to raised areas of mucosa that resemble polyps, but they're not, hence pseudopolyps. So when we talk about memorizing some terms for USMLE, you're going to memorize creeping fat is Crohn. Fine. You're going to memorize that crypt abscesses and pseudopolyps are ulcerative colitis. You're going to memorize that lead pipe appearance, loss of haustra is ulcerative colitis, string sign is Crohn. Okay? So when you do the colonoscopy for ulcerative colitis, as we just said, pseudopolyps, crypt abscesses. For Crohn, you're going to see skip lesions. Okay, and that reflects your string sign, where some parts of bowel are affected, some parts are not. Okay, so let's just continue through the other answers here. Fistula is fucking wrong because you can get those in Crohn disease due to the transmural inflammation. Now, these can go to the skin. You have perianal abscesses. They can go to the genitourinary tract. They can go to the bladder, for instance. There's some weird things that can happen for some of these questions in USMLE. Diverticulitis, colon cancer, Crohn. These are risk factors for fistula development. Okay, and you can get GI flora in the urine, let's say. It's some weird stuff, but they can show up in USMLE questions, especially 2CK level stuff. So fistula, you're not going to see in ulcerative colitis because ulcerative colitis is just the mucosa and submucosa, whereas Crohn is mucosa, submucosa, and muscular is propria. Transmural only in Crohn disease. Fistulae, wrong fucking answer. Choice D, non-caseating granulomas, wrong fucking answer because that's Crohn disease. Okay, so I would say the two highest yield conditions for granulomas in USMLE, sarcoidosis and Crohn, non-caseating. Okay, I mean, you can see non-caseating granulomas in other things, borreliosis. Okay, even in Bartonella henselae, you'll see granulomas. Those are actually going to be caseating. And TB and fungal infections, caseating granulomas. Okay, but I would say Crohn disease, sarcoidosis, and borreliosis, those are the three main conditions I want you to memorize for non-caseating granulomas in USMLE. Then we have to go back to kindergarten for a second. A granuloma is an accumulation of macrophages that coalesce and become multinucleated, and they're going to interact with CD4 plus T cells. It's a finding we see in chronic inflammation. Sometimes you can see them with foreign bodies as well. So different process. So let's say you have suture granuloma. Okay, we have a foreign body, macrophages are attempting to phagocytose, but when you have autoimmune diseases, they can just sometimes occur idiopathically. So no granulomas in Crohn. Fuck am I saying? No non-caseating granulomas in ulcerative colitis, but you do see them in Crohn. Choice C, transmural inflammation is wrong because, as I just harped on, that's going to be Crohn, not ulcerative colitis. Okay, so just some other things you should know: extraintestinal manifestations, ulcerative colitis, classically primary sclerosing cholangitis. If you have a patient who has increased ALP and increased direct bilirubin with jaundice, okay, and ulcerative colitis. So primary sclerosing cholangitis, the patient's kind of increased Qbank titer, and in Crohn, you can get Saccharomyces cerevisiae anti-yeast antibodies, which is a little bit weird. I don't want to go on a 40-minute tangent right now, okay? But just know that you can get anti-yeast antibodies in Crohn, but you can get Qbank in ulcerative colitis with primary sclerosing cholangitis. Also, erythema nodosum, redness of the shins, paniculitis, inflammation of subcutaneous fat, and anterior uveitis are non-specific for autoimmune diseases. You can see them in basically any autoimmune disease, but USMLE tends to associate them with Crohn over ulcerative colitis. Okay? There's a propensity there for Crohn over ulcerative colitis. In contrast, ulcerative colitis, you can get pyoderma gangrenosum, which is a crater on the arm, they'll describe, with necrotic debris. Okay, so don't confuse that with dermatitis herpetiformis, which is celiac disease, where you get IgA deposition of the dermal papillae. Okay, so you got to know that rectum ascending is ulcerative colitis. You get this lead pipe appearance. Crohn disease, mouth to anus. Okay, and mouth ulcers, small bowel, terminal ileum, classically location affected. B12 malabsorption, impaired bile acid reabsorption enteropathically. Okay, so differences you gotta know for USMLE. Choice C, wrong fucking answer.